So at this point, I would like to introduce our speaker, Dr. Segal. If you could turn on your camera and join me here. Dr. Jonathan Segal is a cardiologist with Virginia Heart who specializes in non-invasive cardiology and is board certified in general cardiology, echocardiography, nuclear cardiography, and non-invasive vascular imaging. He's a graduate of Georgetown University School of Medicine, where he also completed his residency in internal medicine, and then went on to do his cardiology fellowship at Albert Einstein College of Medicine up in New York. Dr. Segal sees patients in Virginia Heart's Alexandria and Oakville offices and also provides care to patients in Alexandria Hospital, Inova Fairfax Hospital, Inova Fairfax, Fair Oaks, and Loudoun hospitals. Dr. Segal, I'm going to stop tripping over my own tongue here and hand this over to you. And we look forward to your talk. I will come back at the end and assist with asking questions. Why don't you bring your slides up so everyone can see them? Let's make sure we can see the full slide presentation. That's perfect. That is it. You're on.
Okay. Thank you for the introduction, Warren, and thank you to everyone out there joining me tonight. I'll be speaking about really a fundamental issue in cardiovascular disease. So it's the role of cholesterol and lipids in preventing and managing heart disease. We'll get started. If we can get things to move. Here we go. I have no disclosures. And we'll start with just an overview of the objectives. These are things that I'm hopeful you'll be able to take away at the end of the talk. First thing, I hope you'll understand in a basic sense what lipids are. Secondly, how does cholesterol affect atherosclerotic heart disease? How does cholesterol affect risk of a heart attack? What lifestyle changes could lower your risk for a heart attack? And what medications can we use to help lower cholesterol? To give you an overview further, I'm going to spend the first few minutes talking about really setting the stage, explaining what atherosclerotic heart disease is and how cholesterol plays into it. And then the second portion of the talk is really going to get more into the tools that we have to treat cholesterol disease. So we'll move on to a few definitions. First thing, what is a lipid? This is a fat. It's cholesterol, triglycerides are terms you might hear. In their pure form, these substances do not dissolve in our blood. In order to make them dissolve, to make them soluble, lipids are made into lipoproteins. So these are particles that combine cholesterol, triglycerides, and proteins to form things that you may have heard of, like LDL, low-density lipoprotein, or HDL, high-density lipoprotein, or something you may be hearing more of recently, something called lipoprotein A, or LPA. I want these terms to be in the back of your minds for a few minutes. We're going to get to them more towards the second portion of the talk, but I at least want to set the stage of some of these, set the stage and introduce the players here. All right, so I want to take a 10,000-foot overview of atherosclerosis. I want to emphasize that though this talk is really about heart disease, atherosclerosis is a systemic disease. It affects the arteries throughout the body, not just the heart. To illustrate this point, you see two trees on the screen. They're crepe myrtles. The tree on the left lives in my neighbor's yard. It's healthy. It has smooth brown bark. It's happy. The tree on the right, of course, is in my backyard. If you look closely, the bark is darkened. If you look even more closely, you can see these little white specks that are all over the tree. This is something called crepe myrtle bark scale, which I've recently learned about. The point I want to make is that this disease affects the entire tree. It's not just involving the trunk or the limbs or the branches, it's the entire tree. Just as atherosclerosis affects the entire body from head to toe. So you may also hear of the arterial system in the body referred to as the arterial tree. It's analogous to this. So just because you have atherosclerosis known in one region of the body, it's important to conceptualize it as being everywhere in the arterial system. It may be of varying degrees of severity in different areas of the body, but it's important to understand that it is systemic. So we'll take a minute just to go over some anatomy. The picture in front of you is taken from Gray's Anatomy, which is a fundamental anatomic textbook. What it's showing you is a picture of the heart, and outlined in red are a depiction of the coronary arteries. So the coronary arteries supply blood to the heart muscle. They're referred to as coronary arteries because they are thought to envelop the heart almost like a crown. And what happens with atherosclerosis is you have deposition of cholesterol that forms plaque in the walls of these arteries. Over time, that plaque can expand and ultimately can limit blood flow through the arteries, almost like an old pipe in your house that has buildup of all sorts of minerals from time. The way this happens is complex. It involves all sorts of mechanical factors, biochemical reactions, inflammatory changes. It's a whole process, but the point is that cholesterol deposits in the arteries and it can lead to blockages, and it can go anywhere it wants. So all of the arteries that you see in this picture can be affected in varying degrees. But I hope this illustrates in a basic idea what's involved here. What we have here is an angiogram. So what an angiogram is it's essentially an X-ray that shows blood flow through an artery. When plaque builds up to such a degree as to block blood flow, we can see it through an angiogram. When blood flow is cut off completely or in a very severe or extensive manner, it can lead to a heart attack. And what we're seeing here on the left is an artery that is essentially cut off midway through. So, and hopefully you can see my mouse here, but what we're seeing is this artery that essentially stops there. The picture on the right is after an angioplasty. So what's happened is an interventional cardiologist has essentially, for lack of a better analogy, snaked the drain as a plumber would, and they've pushed the plaque out of the way, and they've reconstituted the artery that you can now see extends all the way over to this aspect of the screen. And if you look closely, you can actually see this darkened thin line here, which is the wire that was used in order to open this artery. So if cholesterol builds up too much and obstructs the flow of blood, this is what it looks like. This is bad. This is what we're trying to prevent. This is a heart attack. This is our attempt to fix it in a mechanical manner. We hope that we don't get to this point. We hope that we can try to prevent a patient from ever needing to go to the cath lab and to have this procedure done. This is another example. This is taken from a textbook. But you can see again, so this is another angiogram. The photo on the left shows a very tight narrowing. So there's just a sliver of blood flow getting through this narrowing. It's basically, it's almost as though there are two arteries here being connected by a string. After being fixed, we look on the right, and the artery has been reconstituted, and blood flow is now restored. Another example of an angiogram, another example of somebody who had a true or near heart attack that we are trying to prevent with medication. This is another illustration of what happens when we have a heart attack. So this is a gross specimen. So this is from an autopsy. This photo was taken from another fundamental textbook that we use in medical school. And what we have here is a cross-section of a heart. So Here we see the left ventricle. This is the cavity of the left ventricle. Over here, we see the right ventricle. And what's been shown is this heart muscle has been stained with a chemical that turns the viable muscle red. If you look towards the top right of the screen, and also towards the bottom left of the screen, there are two large areas that are white, yellowish white. These are areas of scar. So what's happened here is this person had a heart attack. Blood flow was cut off in one of their arteries, just like we saw in those angiograms. And the heart suffered because it wasn't able to achieve, or it wasn't able to obtain the nutrients and the oxygen that it needed in order to live. And blood flow wasn't restored in a timely enough fashion. So the muscle actually dies. It dies and it scars over, and you can see it in a gross specimen. So the purpose of putting these pictures up is to give you a flavor of what is actually happening in the body when cholesterol deposits in the arteries of the heart and causes significant blood flow reduction and can lead to serious and permanent damage. The purposes of these illustrations is to show how important it is that we do the best we can to prevent this from happening. And I hope over the next few minutes, I can show you that we have tools that we can use to do that very thing. So, what contributes to plaque formation? Cholesterol is a big player, but it's important to understand also it is not the only player. So, high blood pressure contributes, diabetes, high blood sugar contributes, smoking contributes, genetics and family history contribute. We're going to focus mostly on cholesterol here and treatments for cholesterol, but it's very important to understand that these other factors are major players in the risk and the role of developing atherosclerotic heart disease. So we try to get people's blood pressure down, we try to get diabetes under control, we quit smoking. I often tell patients who smoke that really there is no medicine I can provide that is as good as quitting smoking. It is a key fundamental intervention. And we counsel people based on their genetics and their personal family history. All right, so let's talk for a moment about the players. So we have the good, the bad, and the ugly. We'll start with the good. HDL, or high density lipoprotein, is often referred to colloquially as the good cholesterol. We tend to think that the higher this number, the better off we are. We want the HDL number to be higher than about 40 generally. It has anti-inflammatory effects, anti-inflammatory properties, and it prevents progression of cholesterol plaque development. That's the current thinking. There's some nuance to this. There is thinking that if HDL is too high, generally maybe above 90 or 100, it can actually increase risk. That's still being borne out. It's not well understood, but there is a signal towards that. LDL, so this is the bad, right? So low density lipoprotein. This is the stuff that we're really trying to get down. It is well known to be insulting to the arteries. It is the main component of plaque formation. It is inflammatory. And the higher the LDL number in the blood, the more likely you are to form the plaques that can then grow and lead to the heart attacks that I was demonstrating on the prior slides. So a major tool or a major goal of our treatment is to drive LDL down. And there are various goals for what an LDL level should be depending on a given individual. We can touch on that a little bit, or if you have a specific question about that, we can address it towards the end. Generally speaking, for a random all-comer person, we like to have LDL below 100. All right, the ugly. So lipoprotein A, or LPA. This is somewhat of a newer kid on the block. So LPA is a special form of LDL. It is increasingly recognized to promote atherosclerotic plaque development. People who have higher LPAs are at higher risk of heart attacks and stroke in the future. It's still very much under investigation. We don't have a well-defined LPA target, except to say the higher, the worse. But generally speaking, I think the current thinking is probably you want an LPA at least or as high as 75, ideally below 75, or even below 50. But that is very much a work in progress, and we could see that number and like will change over time as more research comes out. This is largely a summary of the targets of varying cholesterol levels. Your total cholesterol, we tend to target below 200. And again, this is for all comers. So total cholesterol below 200. LDL, which is the bad, below 100. HDL, which is the good, greater than 40, and arguably less than 90. Triglycerides, less than 150. And lipoprotein A, as I was saying before, the goal really is not yet well established, but the lower the better, probably below 75 or even below 50. All right, so what do we do with all this information? We've laid out the disease itself. We've laid out some of the major players in this disease. How do we know who to treat? We're going to focus on people with no known heart disease. So this is the all-comer average person. They've not had a heart attack. They've not had a stroke. They want to know, what is the risk in the next 10 or 30 years that I could have a heart attack? How do we assess that? And what can we do to lower the risk? So step one of that process is screening them with this tool that you see in front of you. This is the American Heart Association Prevent Calculator. This is an open source thing. You can go online, you can Google this, you can play around with it, you can make up some numbers and put them in and see what your risk is. What we do here is we take the person's demographics and some of their data. So we want their gender, their age, their total cholesterol, their HDL, their systolic blood pressure, so that's the top number in your blood pressure, the body mass index, and their kidney function, and then some other basic information, whether or not they're diabetic, whether or not they smoke, whether or not they are taking medicines for blood pressure, and whether or not they're taking medicines for cholesterol. You plug that information into this calculator, and it spits out a number. And the number is the likelihood of your having an event, essentially a heart attack or a stroke, in the next 10 years. And it's a percent. People with less than 5% are considered low risk. People 5 to 7.5% are in this gray zone. People 7.5 to 20% are intermediate, and people above 20% are high. The general rule of thumb is if you are less than 5%, you probably don't need treatment at that point in time. Probably, but there's nuance to this conversation. If you are in the gray zone of 5 to 7.5, you need to have more of a conversation. You have to go over other risk factors that you may have that are specific to you, and then decide if treatment might be appropriate. Really, anybody above 7.5 should be on some cholesterol lowering therapy. That's the general rule of thumb. But I want to point out a couple of things here. This is just one tool. If you notice, LDL is not included in this tool. That is not to say LDL is unimportant. LDL is critically important. But this tool was designed not to incorporate that data. Similarly, lipoprotein A is not included in this tool. family history are not included in this tool. That does not mean that those factors are unimportant or not relevant to this decision. They're extremely important. And so this is a guideline. It is not a black and white issue or set in stone. And what I often will counsel patients on is they might have a less than 5% risk or a less than 7.5% risk, but their LPA would be high, or their LDL is high, or their parent had a heart attack at a young age. That is critically important. And with that information, we may conclude that even though their risk is low based on this calculator, there are other factors that elevate the risk and would make it beneficial to them to potentially be on a cholesterol lowering medication. But I want to put this out there as a tool that you can access and that you can play with, and that you can use when you come in to see your doctor to have an informed conversation. So what I want to get to next is something called cholesterol years. This speaks to the concept of the longer you have high cholesterol, the higher risk you are. Some of you may be familiar with the concept of pack years, which refers to smoking history. A pack year means how many packs of cigarettes do you smoke a day and over how many years do you smoke them? And that informs various other issues related to smoking. A similar concept is coming out related to cholesterol. So a question that's often brought up is, well, my cholesterol is intermediate, I'm young, do I need to be on a statin? Or I'm a bit older, my cholesterol is low, do I need to be on a statin? And this article from 2020 tries to address that question. Here's the main thrust of that paper. If you look at this graph, you have age on the bottom axis, the x-axis, and you have cumulative cholesterol years on the y-axis. And you have 4 different categories here. One is the person with very high cholesterol from a young age. In orange, you have a moderately high cholesterol. In yellow, you have a mildly elevated cholesterol. And in green, you have a low cholesterol. And across the top here in this dotted line is a threshold by which when you cross this cholesterol year threshold, your risk of atherosclerotic heart disease increases. So the concept here is, how quickly is a given individual going to cross this threshold? If you have high cholesterol from a young age, you're going to cross that threshold here, relatively young. If you have a low cholesterol throughout life, you may never really cross that threshold. So again, this is conceptual. It's being researched further, but the idea speaks to the goal of lowering cholesterol really as soon as we can, because our hope is to keep you below this line. We think if we can keep cholesterol low for as long as possible, we may stave off atherosclerotic heart disease forever. That's our goal. So what can we do about it? Now we're going to move into the portion of the talk that really talks about our tools. So first thing, lifestyle modification for everyone. So whether you have high cholesterol, low cholesterol, doesn't matter. These are things that everybody should strive to do. And what I've done here is I've put up a few articles, not intending for you to read them, but I wanted to make them available to you, that illustrate these points. First thing, plant-based diet. There's increasing evidence that a diet higher in plant-based foods, less animal product, prevents heart disease. There's some data to suggest that higher plant-based diets can actually cause regression of atherosclerosis. So those plaques can actually decrease in size. Generally, what I counsel people to do is to have at least 50% of your calories coming from plants. In a perfect world, we'd be really more vegetarian or vegan, but we do the best we can. So if you can get at least 50% of your diet from plants, I think you're in good shape. Next thing, quit smoking. There's no amount of smoking that is good. Quit smoking. Thirdly, move. Physical activity is important. So, as we say, an object at rest stays at rest, and an object in motion stays in motion. Physical activity lowers mortality. Generally, you want about 75 minutes of intensive exercise a week, and about 3 hours of moderate intensity exercise a week. Medical therapy. So beyond lifestyle, what drugs do we have at our disposal that can lower risk? And you're going to hear about these, and you're going to see these in the news when you go to the doctor. These are common therapies. The most common one you're going to hear about are statins. So the typical names are atorvastatin, rosuvastatin, simvastatin, pitavastatin, pravastatin, etc. Another one you may hear of is called ezetimibe. A third, which is a bit newer, bempedoic acid. And a fourth, also relatively new, but really used all over the place now in the last 8 years or so, are PCSK9 inhibitors. Brand names are Repatha and Praluent, which you may be familiar with. Otherwise, evolocumab and aliricumab. We'll spend a few minutes on statins. So what I've put up here are just an example of the data supporting statin therapy. Statins have been around for 30 years. I think the initial trial was in the 80s. A major trial it was called the 4S study in 1994 that studied simvastatin. And you can see just examples here of the rest. The bottom line is that statins reduce heart attacks, they reduce cholesterol levels, and we have hard data to support that going back 30 years. Statins are tried and true. The way they work is they prevent cholesterol production in the liver, and they also promote cholesterol resorption from the blood. They are once-a-day medicines. They're generally easy to take. They are generally affordable. And the rule of thumb is that if you initiate statin therapy just at the lowest dose, you can lower your cholesterol by about 30 to 50%. If the expectation is 30%, if you're a good responder, you can lower your LDL by 50%. Side effects related to these, the most common thing are muscle aches, which we'll get to at the end for a moment. They're really not that common. Do they happen? Yes, but they're not as common as you may think. The next medicine is called ezetimibe, or Zetia. So this is generally not a first-line medicine. We often use it in conjunction with statins, but they work, and they lower your cholesterol, or they lower your LDL by about 10%. That's the general expectation. They're pretty well tolerated as well. Some people complain of abdominal pain, muscle pain, or sometimes a change in the liver. These are not common, and generally not severe, and they can always be adjusted as needed. The next drug, so this is bempedoic acid. This is one of the newer ones. It really made a splash about 2 years ago. It made it into the lay press as well. So you may have heard on NPR in March of 2023, or you may have seen an article in the Washington Post of March 2023 as well. These drugs really are great because they don't cause muscle aches. So unlike statins, which lower cholesterol in the liver and by function, well, they don't lower cholesterol in the skeletal muscle, but they can affect the skeletal muscle, which causes muscle aches. Bempedoic acid is not processed at all in the muscle. It's only processed in the liver. As such, these are great medications for people who are statin intolerant, so people who have had side effects from statins. The expectation is that you can lower your cholesterol here by about 20%, And the data is even quite stronger to say that the extent to which your LDL drops using bempedoic acid, the benefit in terms of prevention of a heart attack is similar to the same reduction you would achieve with a statin. All right, so if you were to lower your LDL by 20% with this medication and lower your LDL by 20% with a statin, the preventative value of that are similar between both drugs. So this is a great option for people who have muscle aches. It may exacerbate gout, but otherwise they're very effective for our purposes. The last class of drugs I'll talk about here is a PCSK9 inhibitor. These are very effective. They're generally not first-line therapies. They're injectable, but they can lower your cholesterol by your LDL by about 60%. They are excellent medications, and they are generally very well tolerated. I'll touch briefly on calcium scores. These are something that you also may hear about if you see your cardiologist. A calcium score is a CT scan that looks to see if there is calcium in the arteries of your heart. The presence of calcium equals cholesterol plaque. And the higher your calcium score, the higher your risk. So people who have concerns about, or people who want to further define their risk may be candidates for calcium scores. And the higher your number, that informs how aggressively we should be treating your cholesterol. And what I just want to draw your attention to on this graph are the top two lines. So the x-axis here, so horizontal axis, represents time to a heart attack. And then the vertical axis represents the incidence, so how often this really happens. And if you look at the top lines here, one in yellow and one in purple, the yellow line represents people who've had a heart attack in the past. And the purple line represents people with a calcium score above 300. So you're going to get your calcium score, it's going to be a number. And the point is that people who have calcium scores above 300 are at risks similar to people who have previously had heart attacks, and they should be treated aggressively as such. These are very helpful tests to undergo, very useful information. The one caveat is they are often not covered by insurance. Don't quote me on this, but they generally cost a couple $100. What's the point? The point is that we can prevent heart attacks. Just briefly, a word in the future. I think where we are trying to go in medicine is we're trying to identify a given individual's risk-enhancing markers. So we want to see who has high LDL but low LPA, who has high LPA but not so bad LDL. And there are various other markers that are being studied. And I think where medicine and pharmacology is really trying to go is, can we develop medicines that target an individual's specific risk factors? We're not there yet, but I think that is the grand view. In the meantime, we have very effective medication to lower LDL, which is the main risk factor that we have the ability to target at this time. As far as LPA, while we're on the topic, no medicine is approved by the FDA at this point that lowers LPA, but there are many in the research pipeline that are showing promise. A few frequently asked questions. Does lowering LDL cause dementia? Here's a study from just this past month. After 5 years of follow-up among people with an LDL of 35, there's no change in cognition. So to answer this question, there really is no data, no strong data to suggest that lowering LDL too much causes dementia. Do statins cause muscle aches? So it's hard to pin down this exact number, but the thought is between 0.02 and 0.3% of patients taking simvastatin have muscle aches, and that is dose dependent. The lower the dose, the less likely this is to happen. The point is that very few people actually suffer muscle aches. Do statins increase blood sugar? Maybe. They may increase blood sugar a bit. However, there are numerous studies that show that diabetics have lower incidence of heart attack and stroke when they take statins. Do statins cause liver damage? Rarely. 0.5 to 3% of patients have elevation in their liver enzymes, and this is generally dose dependent. So the lower the dose, the less likely this is to happen. And then the last thing, which is a much more nuanced question, if your HDL is high, does that lower your risk? And do you need to take a statin? Yes and no. If your HDL is too high, your risk may actually increase. So HDL is protective, generally thought to be between about 40 and 90. But there is a study just recently in 2024 that took people with an HDL of 98 and scanned them for calcium. So they did a calcium score, and people with calcium had high HDLs, or vice versa. People with high HDLs had calcium, and those that did had a 3 times higher risk of having an event than those that didn't. So HDL is largely thought to be protective, but just because your HDL is high does not mean you should not think about this problem holistically and consider other screening tools when deciding whether or not to take a cholesterol-lowering medication or adjust your lifestyle. So with that, I thank you. I'm happy to take any questions. And if any of you know how to treat my crepe myrtle tree, I'm all ears. Thanks so much.
Thank you so much, Jonathan. That was great, but I don't think we're going to fix the tree tonight. If you can pull your slides down, that
Sure. Give me one second here.
We've got a lot of questions, and I apologize in advance. We're not going to get to them all. I'm going to try to put them together in categories of questions and see how many we can knock off. So, Jonathan, I'm going to feed you a bunch of questions. Let's try to see if we can kind of be succinct in our answers.
Sure.
A lot of questions about diet. You know, everyone wants to know, can I just be on a diet? Can I just switch my diet and not have to take medication? So, you know, you touched upon plant-based diets and that there is a benefit to a plant-based diet. People want to know, you know, are you an advocate of the teaching and advocacy of people like Dr. Caldwell Esselstyn or Dean Ornish, who believe that diet alone, plant-based diet alone is the cure-all and we shouldn't be taking medications at all? Or do you think it's something that we should be doing together? We should be on a heart-healthy diet, whether that's a Mediterranean diet or a plant-based diet, but also medications when indicated, since they have been shown to reduce the incidence of heart attacks and death?
Yeah, great question, and it's a nuanced question. So the answer that I would give is yes and no. So I think a plant-based diet is good for everybody. Whether that is good enough to prevent you from needing medical therapy really depends on any individual specific case. Plant-based diets can lower cholesterol. There is some evidence to suggest that they can reduce plaque, so cause plaque regression, which is what we want. But to make a blanket statement to say that a plant-based diet alone and exercise alone is adequate, it depends on the individual case. And so that may be the case in some people, and it may not be the case in others. And some of the tools that I discussed, like calcium scoring, can really help inform that decision.
But let's go back to that, because I think that's sort of a critical issue. A lot of people ask, well, you know, I have an LDL, let's say of 160, okay? And you may have mentioned that sort of the cutoff for primary prevention is an LDL of 190. Like anyone with an LDL above 190 should be treated. But I have an LDL of 160 and I don't have other risk factors. What should I do? Is the coronary calcium score a helpful decision maker in that situation?
Yeah, absolutely. So if your only risk factor that's identified is an elevated LDL, what I would generally do is plug your data into that prevent score and see what the number is. It may be that your risk is low over the next 10 years, and then we might be able to say, listen, the data at this point suggests that you actually don't need therapy and just keep doing healthy diet, lifestyle, and that is probably adequate. Alternatively, you may have a borderline risk. Keep in mind that a person's biggest risk factor is their age, and there's nothing we can do about that. So your risk is going to change simply because you're getting older. So you may find that your risk at age 50 is less than 5%, but your risk at age 60 is 5.5%, and you're in that gray zone. So calcium score could be really helpful to help adjudicate that question.
There were a couple of questions about how come there's no risk score for a 75 or 80-year-old? Above a certain age, those risk scores, you have to throw them out the window because, 7.5% risk when you're 80. Yeah, everyone's going to fall into that group.
Correct.
Unfortunately, some people, just let me just finish up on diet because, there were questions like, how do I know what's a good diet? How do I get some information? There are a lot of books out there. And I believe that on the website, there are some references to publications about Mediterranean-based diet and things of that nature. But there were some questions about dairy products and cheese. And I found in my practice that people think they're on a very heart-healthy diet, but they're eating a lot of cheese. And is that heart-healthy, Dr. Segal?
I would say everything in moderation.
Okay.
So, and I'm also not a cheese expert, except to say that I also eat cheese and I like cheese. It's I wouldn't eat it all day, all the time. Everything in moderation.
A great question on statins. So if I'm taking a statin, can I eat anything I want? Does that, like, I can go out to every drive-through restaurant and order my junk food, or do I also have to be on a reasonable diet?
Yeah, the answer to that is no. So you have to be on a reasonable diet. The statin is there to help. It is not 100% effective and protective in that manner.
I think you hit a bunch of the questions about statins and dementia, statins and diabetes, statins and the liver. But folks who have some underlying liver disease, are there medications that they can take for lipid lowering?
Yeah, good question. And PCSK9 inhibitors, so the injectable medicines that I was talking about, are probably safe. It's a nuanced question. Depending on the exact nature of your liver disease and various other factors, some medicines may actually be safe despite your impression. So I want to speak to that question in very broad strokes because it is a nuanced question that's really best addressed by an individual's doctor.
Yeah, there were a bunch of questions about sort of the relationship between HDL and LDL. Like, I have a high LDL, but I also have a high HDL. Am I okay? And I think you touched upon that. But still, our major risk factor that we still use traditionally is LDL, right? I mean, that's really the most important subsegment of lipids for us right now.
Yeah, I'd agree with that. LDL has been thoroughly studied. Some of the other factors like LPA that I was talking about we're getting more and more data on them, but they are still investigational to a degree. LDL is very well established at this point to be a major risk factor. HDL is protective, or it's thought to be protective in a range. So you want it to be probably above 40. But again, as I was saying earlier, there's actually signal towards increased mortality in people who have HDLs closer to 100. And calcium scores can, again, help adjudicate that question. So it's something to bring up with your doctor as well.
Another topic that we will talk about another day, it refers to blue zones, parts of the world where they just don't have coronary disease, atherosclerosis, and we should all probably move there, but that's going to be multifactorial. I had another question here. Well, one of the questions, and you sort of you touched upon this tangentially, at what age should we be starting to treat hyperlipidemia? I mean, if you have a teenager who has a significantly elevated, lipid profile, and you're going to want to know their family history and all their other risk factors, but they're too young to get a coronary calcium score, right? When are we going to start treating people?
Yeah.
Tough question.
So this is the $64,000 question, right? So this is where all research is going to be going over the next 10 years. That the cholesterol years issue that I brought up is trying to get to the heart of this question. No pun intended there. But the thrust of that paper is basically we should be screening people when they're young. So if you're 20, you should get your cholesterol checked. That's the argument that they're going to put forth. And as more data comes out about the effect of intervening upon 20-year-olds, we will have a better idea of how effective those medications are in that subset of people. This is the next step.
Yeah, I'm going to apologize to folks who are like throwing questions down there like crazy right now. I'm not going to be able to read fast enough and also feed questions to Dr. Segal at the same time. But if there are really some unique questions there, we will try to answer them after the webinar if we can. There was a very interesting question that came up about apheresis, or almost like a form of dialysis in which we can actually remove fats from people's blood. But that has a very, very limited indication. It's not for someone who just has a mild elevation of any of the segments that you've talked about. Is that right?
Yeah, it's a highly specialized technique. It's generally, my understanding, for people whose triglycerides are really through the roof, so on the order of the thousands. That is a complex issue and really a topic for a different discussion.
And I will say we do have an orphan program here in Northern Virginia. It does exist. And if you are someone or you know someone who has these really sky high, incredibly high numbers, then please speak to one of the cardiologists and you can be referred. I think you've answered this, but there were a couple of questions about it, Jonathan. Which is the more dominant predictor of disease, the good HDL or the bad LDL? And I guess I think I see a lot of patients that come in and tell me, well, my LDL's been high, but my doctor told me my HDL is high, so I'm safe, I'm protected. Do you buy into that?
I would focus on the LDL. If your LDL is high, I would consider that a stronger risk factor than the protective effect of an HDL.
How about fish
That
oil?
question.
Does fish oil have a role here?
So fish oil, that's a good question. Fish oil is at this point largely used to target triglycerides. There's a fish oil can refer to basically omega-3 fatty acid that you can buy over the counter. There are prescription forms of this, a drug called Vascepa, which is a long name, alternatively icosapentaethyl. It's very good. It lowers triglycerides. It is also shown to reduce events in people who have triglycerides and elevated LPA. It's a good drug. I use it in the appropriate population. I will stop there before getting too much into the weeds. But yes, fish oil is useful.
And so are fatty fish in your
Yeah,
diet.
exactly.
That's
What
also
I was going to say is you could argue that
that's
the
right.
stuff you get over the counter is as effective as the prescription, but things you get as supplements are not regulated, whereas prescription drugs are. So you know what you're getting when you get a prescription drug. When you get a supplement, you don't necessarily really know what's in there.
So side effects of statins and muscle aches, and someone asked about CPK levels, right? So sometimes your doctor may check a blood test called a CPK or a CK if you're having muscle aches. What does that mean exactly?
Yeah. So CK can indicate a degree of muscle injury. This is a complicated question. People can have elevated CPKs for various reasons. So I don't want to get too much into that. But if you are having a side effect related to a statin, generally in the form of muscle aches, the blood test that could correspond to that would be an abnormal CPK. If yours is found to be abnormal, then you could try lowering the dose of your statin. You could stop the statin. You could switch to a statin that is known to be less likely to cause muscle aches. and then repeat the numbers and see how you do after the change and see how things are going. That's the general idea.
Yeah. What are your thoughts about CoQ10? Is
Yeah.
that something that you recommend?
There's no strong data behind it. I'll put it to you that way. If you're on it and you think it's working, that's fine. I generally do not actively prescribe it.
Okay, I have a question that I don't expect you to know the answer to. Okay, I had to go Google it. I'm just going to tell you that. Okay, do you know anything about the use of berberine? It's a plant extract that has been recently shown to have some beneficial effects on risk reduction. Um, have you heard anything
I
about that?
don't know.
Got
I
it,
don't
like
know.
mea culpa, right? Don't
Yeah,
know anything about it.
I don't know.
Okay. But for the person who asked that question, I did Google it. There's some information on it in an NIH study. I'd encourage you to go look at that. And, I think all of these other things, I'm just going to express my opinion now, right? They're, not a bad idea. Go ahead, go ahead and do that, but don't ignore evidence-based medicine's guidelines right now. And what a lot of patients don't understand is the way we come up with these recommendations is we're not shooting from the hip. These are studies that are done with tens of thousands of patients. And we're looking at groups of patients, and some are being treated one way and some are being treated another way. And we see which group does best and which group has a lower incidence of disease and the lower mortality. And those are the recommendations we follow. And as new data becomes available, we may change how we do things. But understand that when we talk about evidence-based medicine, it's based on large, scientific, well-controlled studies that are guiding us in helping make recommendations. And I just think that's something that folks don't get, right? A couple of questions about older patients and really not knowing what to do about risk modification because the risk calculators really don't help you a lot over the age of 70. And so how would you counsel a patient over 70 who does not have known vascular disease, but has risk factors and a moderate, lipid elevation, has an LDL of 135, borderline blood pressure, maybe they're on some blood pressure medicines. What should they be doing?
Yeah. So lifestyle, of course, is good for everybody. This question really comes down to a conversation with the individual. I think calcium scores still have value in that population. A relatively low calcium score in a patient who's 75 is actually very reassuring because that person's lived 75 years and their calcium score is relatively low. So you could make a strong argument, I would say, that you may not really need anything beyond lifestyle in that patient. Conversely, the patient who is 30 years old, whose LDL is good, but has a calcium score of 1, is actually much higher risk because they've only been around for 30 years and they have hopefully another 50 years to go. And so their chances of developing disease over those 50 years is much higher, and they've demonstrated a propensity towards it at a young age.
I'm going to give him 60 years, Jonathan.
Okay, 60 years. 60, okay. Yeah.
I'm just pushing that
All right.
Okay. A couple of, we've talked a lot about coronary calcium scores. I don't think we've explained exactly what that is, how it's done.
Yeah.
There were a couple of questions about how much radiation is that? Should I be afraid of a coronary calcium score? Are they putting an IV in my arm? Are they giving me dye? How long does it take? You want to just real quickly
Yeah, sure. This is a very basic CT scan. I can't tell you the exact radiation, but it's less radiation than a standard CT of the chest for a more involved reason. There's no IV involved. There's no contrast involved. You just go in and out of the tube. Takes a minute or less, and you get your answer. It's a very simple, straightforward tool. That's part of its appeal.
Yeah. And the other thing I found folks are confused about, especially women who come in who might be on some calcium supplements for osteoporosis. And we talk about coronary calcium and we talk about oral calcium for bone health.
Yep.
Those are two different things, right? I mean,
different things.
The one has nothing to do with the other.
Correct. So, protect your bones. It's not going to affect the coronaries.
A couple of people were curious about, you showed some pictures of coronary angiograms, and an angiogram is a picture of, there were these questions. An angiogram is a picture of, an X-ray picture of any artery in the body, it doesn't matter where.
Correct.
A heart catheterization, you're doing coronary angiograms, you're taking pictures of the coronary arteries.
Correct.
But when someone comes in and has that heart attack, what is it that the cardiologists are doing to stop that heart attack, and how's it done?
Sorry, you say it one more time? For what?
Basically, what is a percutaneous coronary intervention? What are we doing for patients with heart
Got it.
attacks? How are we stopping it and preventing muscle damage?
So basically what's happening there is a patient comes in, they have a blockage in their artery, and you go to what's called the catheterization lab on an emergent basis generally. And the basic principle here is you are able to put a large IV, for lack of a better word, in an artery, either in the wrist or the leg, at the level of the thigh or the groin, and you push that thing up the arm or up the chest and get it to the heart. And this is all visualized under an X-ray, it's all live. And then you inject contrast, which lights up under an X-ray and provides you.
We're going to have to we're at the end here, so I'm going to have to abbreviate this real quickly. But basically, we're put a little wire down there, we're blow up a balloon, get the blockage out of the way, inflate a little scaffold or a stent. It becomes part of your body. You don't have to worry about it. You have to be on certain medications, but I'm going to have to finish because we're out of time. I'm sorry. So I need to thank Jonathan Segal, Dr. Jonathan Segal, for being with us here tonight. This was a great presentation.